Next session takes us into the world of innovation, exploring how technology, investment, and creative partnerships are shaping the future of behavioral health. We're honored to be joined by Jay Chaudhry, Senior Fellow with Sagamore Institute and former Director of Indiana's Division of Mental Health and Addiction. I've worked with Jay. I've seen how he has made an impact in his incredible work to push more resources out there to fight addiction. Jay has been a driving force in advancing systemic innovation and building connections across sectors to better support the mental health of Hoosier families. So to kick off this important conversation, please join me in welcoming Jay Chaudhry.
It's much better to be introduced by Rachel than to be interviewed by her, I will say. It's great to be here. I'm really excited about this panel and kind of can't believe that all of these folks kind of agreed to do this for us. I know this is the panel right before lunch, so I'm sort of obligated to make a reference to that. So just think about like the best joke you've ever heard in that context. Imagine I said it, and then we can move on from there. So this panel actually comes together kind of beautifully thematically in a way that I didn't anticipate. Because I was talking to a large employer last month, about 6,000 employees, mission-driven. Don't want to give away too much information because they haven't, given me permission to talk about them. But they about a year ago made a huge commitment to the mental health of their employees. By giving essentially as a benefit, kind of concierge mental health services, kind of on demand. Not through an EAP, just on demand with a provider. And they were about a year into this, and we were talking about what they've seen, right? And so there was 3 big takeaways from what they've seen. They've seen, for the folks that have utilized it, just incredible results, like happier, healthier, more productive, just generally just better, happier employees. That's kind of like the good news top headline, which is really important. And then a couple interesting and maybe a little bit more nuanced and complicated things, right? So the second big takeaway was that the costs were skyrocketing. And it's just a fact, right? And the truth is they were worried that they weren't going to be able to continue this because they saw it as an investment. They saw it as something that would give, pay off 3-4 full down the road. But the availability of free cash is the reality of any business. And if you don't have the ability to invest in something up front, it doesn't matter what the ROI is 5 to 10 years later, right? And so they were really worried about the cost. And the third thing that was so interesting was when they were surveying their employees about this, the number one thing that came up was families, right? Yes, my mental health may be a concern, but I'm really worried about my daughter or my spouse or my stepson. And there's really no difference between a person's mental health and their family's mental health. It's all kind of the same thing. And so what our panel here today is here to talk about is a few different things. So first, how can we leverage technology in kind of new and innovative and cool ways to bend that cost curve without sacrificing availability or access to services, because that's something I think we all want to do. And then second, how can we start to view families as the unit of intervention, not just individuals, because a family's mental health is an employee's mental health, period. And so our panelists here, and I will let them say whatever they want about themselves, but maybe just say your name and then I'll kind of give a sense of what they're here for. So we'll start with Natalia.
Hi, I'm Natalia.
Hey, so Natalia is the CEO of Flourish Health, which she'll tell you all about. So she represents the kind of provider lens. And so next we have Louise.
Hey, I'm Louise.
Hey, Louise is, I don't know how to describe Louise other than she is sort of a family mental health pioneer, and she's part of this movement that I'm proud to be a part of as well, which is trying to champion and putting families at the center of our mental health system. And then we have Margaret.
And I'm Margaret.
All right, yeah, Margaret Laws.
Go in and saying I'm Seema.
Okay, Seema, go, yeah, great. And so, Margaret is the CEO of Hope Lab, which she'll tell you about, and Hope Lab is just like an incredible organization that is, leading the charge in youth and family behavioral health. And then, Seema's worn many hats. She's been an advisor to Governor Pence and sort of say one of the reasons we have Medicaid expansion in Indiana. I think it's a true statement. Also ran Center for Medicare and Medicaid Services during the first Trump administration, and now she's at Oracle. And so, as you can see, we have like really incredible kind of national level experts here on this panel, and we're super excited to have them here. So just kind of getting into it here. Let's start with Margaret. Margaret, when we think about technology for behavioral health, it can be really overwhelming, right? Because I think I met Margaret at this conference last year called Behavioral Health Tech, and there's this massive, cavernous room of all these vendors and providers, and you can walk for hours just seeing all these different companies, all these different solutions. It's overwhelming, and I'm somebody who knows a little bit about the mental health space, and I was overwhelmed by this. And so when you're an employer trying to look at the vast array of sort of the behavioral health tech world, it can be really hard. And so Margaret, I was hoping you could maybe demystify that a little bit for us and walk us through it.
Sure. Well, I'll start by saying I can't believe it's only been a year since we've met, but and it's been wonderful, and really appreciate being here and getting the opportunity to talk to all of you. What I would say, I actually lead an organization called Hope Lab. We were founded and are largely funded by the founders of eBay. So we have really tech at our foundation. And because we focus on teens and young adults and mental and emotional well-being of teens and young adults, and as we all know, teens and young adults are now many generations of from digital natives. So we've got to be focused on tech, and we've got to be thinking about the role that tech is playing in the lives of young people and how we can make services available and accessible and affordable. So when I think about sort of the broader landscape, it's been mentioned a couple times already this morning. The last several years have ushered in virtual care, I think in a way that for decades before, many of us in the healthcare system have been trying to do so. COVID really brought virtual care front and center. I think particularly for young people, that's been huge. I don't think we would have been able to pull young people in for the kinds of mental health services and support they need if it was only in-person care. So I think the ability of us to deliver through virtual care platforms is really an important piece of it. Payment is really important, and it's very linked to it, as we talked about this morning. The payment policies that permitted and supported virtual care are in some sustaining and some in question. So I think there's a really important piece around payment. We work with kids and young adults. Medicaid as a payer is a really important piece of the equation. I think one of the other things we think about when we think about investing in mental and behavioral health care companies or solutions or services is that we're in a field where short-term return on investment is a really important piece of the way the sustainability puzzle works. And in many cases, we're dealing with things that are longer term and more prevention focused. So I think toggling between the short-term ROI nature of investment in healthcare period and in healthcare technology more specifically, and some of the prevention needs and the public health needs of the mental health space are a tension that we face. The promise and uncertainty of AI is upon us. And so mental health, for all sorts of opportunities and all sorts of challenges, AI and mental health is something that's a really important topic right now. And then I think just thinking about new modalities, some made possible by AI, some revolutions in drug classes like GLP-1s or psychedelics, we're really seeing some new modalities start to come in. And I think our ability as a healthcare system and a healthcare research community to understand what's working, and then when we find things that are working, how do we get them out and implemented as effectively as possible? So a little bit of the landscape we're facing as we think about trying to get better access and better outcomes in mental health.
Yeah, great. And so of this vast universe, like what are some solutions that you've seen are as promising?
Yeah, I mean, I love that we were able to be here for the morning, because one of the things we talked a lot about, and I'm going to focus a little bit more on kids and teens and young adults, we talked about school-based services. Really I've worked in healthcare and healthcare for underserved populations for, 30 or 40 years. And particularly when we think about kids, being able to make services available where they are and meeting them, particularly lower income or underserved kids in the school environment, and meeting the families through that school environment is a huge innovation. We work with a number of companies, but one called Hazel Health that delivers teletherapy in about 5,000 schools across the country, both to young people and to the parents. They can do it at the school, they can do it at home. So the location, meeting people where they are, a huge one. I think really thinking about the integration of medical care and behavioral health care, ways we can think about, there's a company that Louise and I have both been talking to called Nest that works with high-risk families and moms after they've delivered, and integrates the mental health care with the physical health care of those families. Not just the mom, not just the baby, also the family. That doesn't sound revolutionary, but in our healthcare system, it really is. So thinking about models that can allow that kind of integration, and again, how do we finance them? How do we distribute them? I think some really interesting innovations. I think just generally trying to think about how do we engage consumers and users and people more in care. One of the things we do at Hope Lab is work very closely with young people as co-designers and co-developers of everything we do. We know young people aren't going to use services unless it's something that they kind of validate. And so I think across the board, thinking about, just as the folks on the last panel talked about, how do we engage and really understand the needs of folks we're designing services for? It's a few.
Yeah, and so one of the things that always strikes me about, throw my pen there, that's how passionate I am about this, strikes me about the telehealth, forced telehealth revolution after COVID, right, was that we had the chance, I think, to build something new from the ground up, and instead we just kind of layered digital tools on top of our existing system. And that, understandable, it was an emergency, like there was not a lot of time to plan or think about it. But I think now, and just to reflect on what you're saying, I think what we're seeing now is that kind of built from the ground up with folks who are digital natives, who understand this. I mean, if you have children and you've seen them use devices, they understand these things at a level that we can't even fathom, right? Like, my daughter was able to take pictures at like 11 months old with the phone. I don't know how, right? And so, and so I think that's a really, really, important point that you all are sitting at the kind of intersection of. So, kind of last question for you, Margaret. What's Hope Lab's role in advancing this work? How do you operate? And any other kind of words of wisdom you want to share?
Sure. Yeah, we're an interesting organization. We're an impact investor, so we invest in for-profit companies working out in the landscape of teen and young adult mental health care. We have an innovation lab where we work in co-design with young people. We do give grants, so we've got a grant program called the Responsible Technology Youth Power Fund with about a dozen other funders, supporting young and intergenerationally led organizations, doing everything from movement building to providing services to advocating in DC and at the state level. And then we have a translational research group. So we have a group of cognitive and clinical psychologists mostly, when we're really trying to understand what's happening in the field from our investments and bring back some research ideas to the researchers, and then understand from our researchers what do we know about what's working, and try to help build that into some of the products and services we support through our investments. So, we're a nonprofit organization. We work closely with a number of other family offices, foundations, and other nonprofits, and really try to kind of create this bridge. I talked earlier, we've got things that are very much clinical and in the market. Natalia will talk a little bit about Flourish, which is one of the companies we work with. But we also, on the other end, work on things like purpose. How do you cultivate, nurture, and spark purpose in young people? And we've got a number of projects in that space, really trying to measure the durability and the effect of, if we can help people as emerging adults find the sense that they can contribute to the world, that they matter, that can be a foundation for lifelong mental well-being. And as a philanthropic organization, we have the ability to kind of work on both ends of that spectrum, from the very clinical, it's out there in the market, we can figure out a way to kind of save money, deliver better care, and invest in those kinds of companies, to things where we're really trying to build new models of prevention, and new models that we hope we can figure out sustainable ways to support over time. Do you want me to jump in with the last example of one of those things? Or you want to save that for later?
Can I make a joke first?
Yeah.
So, okay. Quote the great American philosopher Homer Simpson, who once called alcohol the cause of and solution to all of life's problems, right? And so it strikes me right now as we think about tech, right, being, I think we all know, like a driving force of youth and adult mental health challenges. I think it's important to also reframe it as a solution. So that's what I appreciate about what you're doing. But yeah, what you want to end on this super cool example?
So one of the things that we've worked on, again, we have the sort of ability to both be a research lab and be an investor in the market. And we've been working with an organization for many years called COCO, cococares.org. And COCO is basically an AI natural language layer that sits on top of Twitch, TikTok, Tumblr, any kind of social network, detects people in distress, routes them to help with a human helper to text with them, or to a crisis line, depending on what the severity of the issue is, using really sophisticated algorithmic sort of detection and decades of data from Crisis Text Line and others. And one of the things that we have been doing, and through the sort of research in action, is teamed up, COCO has teamed up with a researcher named Jessica Schleider, who does work pioneering in an area called single session interventions. So think about a short intervention, one-time intervention with, let's say, a young person having body image issues, or going on a social media site down anorexia or prorexia kind of trail. What we can do is serve them up, interrupt the algorithm and serve them up a single session intervention around body image. And the platform also can basically study and observe what's happening and check back with that person. And what we've seen with these single session interventions, one of which is being tested at Riley Children's now, is that single session can have lasting effects on mindset, on behaviors, and we're particularly interested in this with young people. So that's just sort of an example of something that's active out there in states, in companies with these major platforms, where we're really trying to come up with things that are cost effective, that can be delivered just in time, and that we hope can actually be a way to meet some of the need where otherwise people would be on long waiting lists. So
yeah, thank
finish
you.
with that one.
And that's, to me, like, just a great example of, so I was at a gathering in Michigan last month, and everybody was fretting about what Dr. Adams very eloquently called the woolly mammoth in the room, right? The federal, just the kind of federal devastation of kind of all of healthcare that's going on right now. And there was people understandably upset about it. And the point I made, and I think that it's worth mentioning here as we transition to Luis, is if, when we start to be able to build back, like that's going to happen at some point. Like if we build back the exact same as we did before, that will be such a shame and a missed opportunity. Like we have the opportunity to build new and better and more family-centered systems, and also ones that reflect our reality in 2025 and beyond, not replicate these systems that developed and these billing codes that developed over a long time before we all had supercomputers in our pockets, right? And so transitioning to Luis, I know I flipped on you, you're supposed to go first, but it made sense to, up here, I called an audible and said it makes sense for Margaret to go first, because I think Luis is a really good sandwich between these two here, like both visually and also as flow here. And so Luis, let's talk about families, talk about family mental health. What is it? How'd you decide to go down this road? What do you see as its promises, challenges, future, all that?
Yeah, well, first of all, if I am lucky enough to be called by you a family mental health pioneer, I have to say you're my hype man. So I feel really good about your role hyping up family mental health. And yeah, I think family mental health quite simply is the mental health and well-being of both parents, caregivers, and children. And it is in some ways as simple as that it is not just about one individual, it's about the entire family. And many of you this morning shared really moving personal stories about your own family interacting with the mental health system, whether that was in bringing an aunt to get treatment or a child to get treatment, and coming back to have to look into the death of a parent. All of those things, I think, are really important examples of what it means to talk about family mental health. I'll just share personally, I kind of first got to know this way of looking at mental health when I had my own children, and my third child got a rare brain diagnosis that was causing him to have a lot of really scary symptoms. He was having trouble walking and talking, and he was 3 at the time. And it was so stressful for my husband and for me and for our other 2 older kids. And I kept thinking, like, I just need to get support, obviously medically for him, but also for my children to make sure that they're doing okay, while I was myself like functioning, but not doing okay. And the minute I went to get help for myself, of course, not shockingly, everyone else in my family, because oftentimes moms are kind of the beacon of the family, everyone else in my family started to do better too. Eventually we got support for everyone in the family, and thankfully my son is doing much better now. But regardless, it was a really very moving experience for me personally just a few years ago to realize at a personal level the impact of, if a child is not well, a parent is not well. If a parent is not well, a child is not well. The good news is the reverse is also true. You can help a parent, you can help a child. You can help a child, you can help a parent. And the data really supports that in a really powerful way. You sometimes actually don't even need to interact with both the parent and child to make that true. So for example, if you are able to treat a mom who is experiencing anxiety or depression, which 20% of moms experience a maternal mental health disorder at least, 85% of those moms don't receive treatment. If you are able to help a mom, and I'll talk later about an example of a company we support that does, you can see up to an 80% improvement, clinically significant improvement in their health and well-being, and the impact on the child is profound. That child does better physically, emotionally, in school. And so there's just huge power in this model of thinking about families as the unit of intervention. It's, I think, actually so intuitive to all of us. But I think especially given what Jay just said, the other promise in it is by helping a family, you can take a different approach to cost. So oftentimes when family interventions occur, they're actually not adding cost. You can see a parent and the child in the same visit. You can serve one to serve the other. And the outcomes and the data are showing that can both make sure that the parent and the child do better and save money. And the example of the mom I just gave, when there's an 80% clinically significant improvement in the mom's mental health, that produces $2,000 on average per mom in savings for the health plan. And that's largely due to the downstream effects of that intervention. So there's a real opportunity for family mental health to kind of lead the way on both impact and savings, which I think in this moment is really important.
Yeah, and one of my favorite examples of this is in Washington State. There's a small mid-sized pediatric practice called Peds Northwest, and what they're doing is they are embedding community health workers in a pediatric practice, which again, none of this stuff is like brand new or revolutionary. We've been using CHWs to great effect for 40, 50 years. But putting it in a pediatric practice and having them deal with the whole family has been absolutely transformative for those families, and also reduce utilization, all the metrics that that we really care about. Because the thing is, like, and this is really important, it's shocking the degree to which our healthcare system's default is the individual, right? Every single thing is based on, if you've ever tried to get information about a loved one or family member without all the proper releases, like, what I'm talking about here, right? And again, it makes sense. Healthcare privacy is super important. Don't want to downplay it. But everything is sort of just the default is the individual. So I'd love for you, maybe Luis, to give that example about how something that you've worked with has kind of flipped that default on its head.
Yeah, so I was teeing up this example of a company that we invested in called Canopy that is an asynchronous support for moms when they're pregnant or after they give birth that is actually first sent to them when they get their breast pump from the health plan, from the Medicaid plan to the commercial plan. They'll get the breast pump, they'll get a little QR code to enroll them in Canopy for free. And when they get that, they get the app on their phone, they then are basically tracking like you would from Baby Center when you have a baby to show you like the size of your baby is now an avocado and now it's a whatever, the different progression of those pieces of information are. It's similar, but focused on your mental health and well-being and that of your baby. And it's largely asynchronous, so it's really focused on catching you with information, with videos, and with community when you need it. And then if you show certain signs using the technology to recognize those signs that you're anxious or you're depressed, it will connect you to care through your health plan. And they've been really successful at getting those moms that are showing those early signs that are not yet a crisis to care when it's early enough that they can really intervene. And the effect of that is that they both help the mom and help reduce the amount of complicated births, which are, as we all know, one of the biggest drivers of cost for the health plan. So Canopy has had some great initial results in Florida, where they work with Blue Shield of Florida, and they're actually expanding across the whole population from 10,000 moms to 30,000 moms there. They also are coming to Utah, just won a state contract with Medicaid in Utah. And I think there's a lot of promise in the model as an example of this kind of early intervention, prevention approach as it applies to moms. As you shared, there are other examples that are actually already in place. So Canopy is like a tech-enabled innovation that's new, that's coming into the market. There's also these examples like Pediatrics Northwest or Healthy Steps, which I think many of you probably know well, a national nonprofit organization that have been using team-based care in the pediatric primary care setting for a long time, bringing in a community health worker, another health professional into the visit when mom or other parent is going into the first year of many visits that you take your child to at the pediatrician. And in those visits, checking on the mom's well-being, checking on whether or not they have the supports for the rest of the family, connecting them to care if they need it. And the results from that program are incredible, both in terms of the outcomes for the child and the parent, and in terms of the cost savings for the child long-term. We're currently backing an effort to demonstrate nationally that that kind of program, team-based pediatric primary care, family mental health, can both have the impact on children and have an impact on parents, and excited to see where that goes, both to prove out kind of the family mental health impact case, but also to prove out some of the innovative methods of payment that currently exist to fund Healthy Steps, and many of you I'm sure know this, like in California, dyadic billing, or in Colorado, newly collaborative care codes that cover this integrated approach to behavioral health, or in Maryland or Arkansas, where there's additional payments that are made for those visits. We're going to try to show that that approach, which has existed for decades, can actually have profound impact. So I think it's both recognizing the examples that are innovative and tech-enabled, and recognizing that there's some that have actually always been here, and that we just need to show both the impact they can have and the savings they can produce.
Yeah, I think the best sort of quote to sum this all up, and where's Steve Viewig? Is he still here? Yeah. So you're going to get mad at me here, Steve, because Steve is the baby guy. He always asks, what about the babies? He already did once today. He might ask it again. I love it, because we need to ask about it. But there's a quote I learned from this field, which is that there's no such thing as a baby, right? And what that means is, no matter what, if you have a baby, some caregiver has brought that baby into the pediatrics office. And like that is, and I think you can extrapolate that, I mean, to any of us. Like none of us are islands. We all, and Luis said it once, like families tank or thrive together. And I think that is, like putting that message at the core of our system and designing around that, I think is the direction that, we're going to be forced to take, right? Whether or not we want to. And so I'm glad to be part of, at that.
They say, I think the quote that a colleague of ours has said is, babies don't go to the doctors by themselves. Yeah. And that's like, it's very easy to imagine, like, oh yeah, they really can't.
Yeah, they really can't do it, right? So two concepts here. We got, Margaret talking about tech and Luis talking about family mental health. So let's kind of put it all together with an example of this in action. So Natalia, I'd love for you to tell us about Flourish, how you deliver care, what kind of results you're seeing, and what lessons you've learned along the way.
Sure. Thanks so much. It's such a pleasure to be here, and it's awesome to be among such a diverse group of stakeholders. Let me tell you a little bit about Flourish and then tell you about a family as an example. So Flourish, we are a technology-enabled services company, which means we use technology to deliver and augment the care that we can provide. We focus on youth with serious mental illness. These are often teenagers who have been hospitalized for a suicide attempt, or youth in foster care who are at risk of facility placement because their behaviors in their foster home are so disruptive. So I kind of think of it as we take the kids that a lot of other clinics can't because of their complexity and acuity. Because we're for-profit, we're able to fundraise with venture capital investing and have been fortunate to raise over $20 million, which has helped us build a program that can really serve appropriately this level of complexity and acuity. So with that, let me tell you about one of the families that we serve. We were referred a patient, keep some of the details private for HIPAA, but around middle school aged, young man in a very rural area who had been suspended from school 4 times in 6 months. He stabbed another student in the arm with a pencil. He attacked, in a different incident, another student with scissors, and he told his teacher he was going to murder her. So this patient was referred to us, and we're equipped to provide care for a patient like that because of our integrated team approach. So every patient gets a child psychiatrist. For any of you out there, you may be familiar with the long wait list for most kids to get a child psychiatrist. Our kids get a child psychiatrist within 4 weeks. They get a therapist. They get a community health worker to work with their caregiver and a community health worker to work with the teenager. So those 4 professionals work together on a shared panel of patients to really wrap our arms around the patient and the family. So what is happening for this young boy in his life? He comes from a family where there's a mom and a dad and 3 kids. There's an older brother, a middle sister, and he's the youngest. Dad is in jail for sexually assaulting the middle sister. Older brother is in residential facility due to his own disruptive behaviors. And it turns out that older brother was sexually abusing him. So there's complex trauma in this family that has not been addressed or unpacked. Mom is the primary provider, both in terms of finances and caregiving. And we think about, employers and best practices. She can't show up to rigid appointments because she needs to keep her job, and she can't take too much time off. So we have been able to, by using technology, provide an intervention that the mom can access on her days off and in the evenings so that she can get the support she needs to adjust her parenting and the boundaries in the home. We delivered really rigorous intervention to this kiddo, partnered with his school, partnered sometimes with the local police and sheriff's office, and 6 months into our care, he got awarded Student of the Week at school. And the mom told us that this was the only intervention that has helped her family, and that she wished all parents could get the parenting education that we provided, and she wished she had had that when all of her kids were younger, and maybe that would have prevented the behaviors that her oldest son had that ultimately hurt the younger kids. And so I just share that because for me, that family ties so much of what we've been talking about, where her ability to stay in her job is critical for this family to be on their feet financially. Our ability to deliver care to a rural family is critical for them to have access. And because we do psychiatry and therapy virtually, but our community health workers are local in person, we can give best clinical care remotely, but still have that in-person human touch that helps families engage and feel really cared about. So that to me was an example.
Wow, it's an incredible story. And so I want to drill down a little bit into the kind of the business model aspect of it. And so, a lot of our work in Indiana over the last several years has been focused on our kind of community-based, nonprofit, indigent serving. I see several of them over here on the table here. You can raise your hands, Christine and Katie. Hi, how are you? I miss you. I miss working with you. So the community mental health center, sort of model. And Brian talked this morning about, how competition, it doesn't need to be competition. So how do you see companies like Flourish and sort of other tech-enabled services companies kind of working alongside and not displacing or disrupting the kind of existing field?
Yeah, absolutely. So I think that companies like Flourish can be specialty providers, whereas often we really rely on community clinics to be, the generalist providers that are able to support 90% of needs.
Yeah, thank you. And then when you think from an employer's perspective, I think that the more awareness and knowledge and the easier it is to kind of learn about the existence of, more specialty or more directive, types of products is super important, super helpful. And I think the chamber can play a big role in that as well in terms of sort of being a clearinghouse for that. Well, thank you, Natalia, and we may come back to you. But, Seema, I want to give you some time and space, given the various perspectives that you've had, and feel free to bring any of those into this discussion. Just kind of reflect on what you've heard and also, what Oracle's doing. Sort of, we've talked about little tech. This is the biggest of the big tech here, or one of them. And so what are you all doing in this space?
Sure. Well, let me start with more of a payer hat, because I think this is a great discussion. And when I was at CMS, I think, at that time there was a lot of attention on mental health. And I think whether it was COVID or just sort of where we are as a society, that there's this growing demand. And I think people are feeling more comfortable in seeking out mental health services. And so from a payer perspective, when we look at the data, I think there's a strong understanding that the provision of mental health care is very important to even overall outcomes on the physical health side. So if we look at cardiovascular disease or diabetes or hospitalizations, we know that when somebody if we can address those mental health issues, it has an impact. So I think that there's that acknowledgement. There's lots of efforts around integrated care. But from a payer standpoint, how do you make that happen? How do you enable that, right? Because they're not on the front lines. They're sort of more in the background figuring out what services to cover and what to pay for. And so the integration piece has been, I think, mixed, right? It works in some places, it doesn't work in other places. It does seem to work when there's co-location. That seems to be the best model, but again, that's not something a payer can effectuate. So we've seen the emergence of more of these, what we call value-based care models, and that's where instead of paying for services, 1, 2, 3 fee for service to do on a more value-based, which is to kind of have a target for the budget and then allow providers to figure out what does the patient really need. And so it could be they need more mental health, they need more physical health, they need more therapy, they need more medication. And it also allows the providers to experiment, right, with all of these different new platforms, these different technologies, and they're not necessarily inhibited by what the payer is going to pay for, right? So as this new and emerging technology comes out, it's allows that provider the flexibility to figure out what they want to use. So I think in some ways when we talk about value-based care, we don't really talk about it for mental health, but I think that this is the opportunity around this area. And there could be also some value-based care models that are very specific just to mental health, right? Where we say, okay, this is this type of individual with these types of issues, and so therefore this is kind of an estimate. And I think to some degree it's hard to talk about the cost side of the equation when we're talking about such difficult issues, right? And I think that there is, you want to help people, and in those situations that there's such dire need. But I think from payers, they also have to balance of how do we make healthcare affordable for everybody, and how do we keep premiums down? So they're making those types of decisions back and forth. I'm not here on the side of payers or providers, but just trying to also put that perspective out there. And then I think from a government perspective, we're talking about a lot of new technology that's coming out, and there's been a lot, whether it's digital therapies or even virtual reality for mental health. And that's where I think the government has a role there to figure out what's effective and what's not. So you sort of see, the FDA exerting themselves around devices, and they're now even sort of looking at a lot of the AI tools and saying, okay, we're going to regulate that because we want to make sure that these things are safe, for patients, and they're effective, right? So if you think about, it's an AI tool. Hey, there's my friend from the government as well. You could give this lecture as well. But I mean, the idea that things may not work, or they could be dangerous, right? If you've got an AI bot and it's going back and forth and it's not recognizing symptoms as somebody whose situation is escalating, it could be problematic. And so I think for the payers, they're very reliant on that process, because you can imagine everyone's knocking on the door and they're saying the exact same thing, which is, I have a product and it delivers great outcomes and it can save money. Everybody absolutely says that, right? So it's like, how do you distinguish that? So I think that there is that's the challenge with all of this new technology, and how do we leverage it, and how do we be careful with it as well. In the era of AI, this is becoming more and more important because AI is moving so fast, and at the same time, the government is not, and I don't think that that's a bad thing. Government never really does move fast. It's not necessarily a bad thing, because you also don't want to inhibit innovation. If the government comes and says you can't do this, this, and this, then all of those investments and things like that don't happen. So I do think it's important in this day and age. So it's a tough time right now in terms of figuring all this out. So that's kind of the payer perspective. The other thing that I think in terms of thinking about this problem around mental health is also thinking about the health of the providers themselves. I mean, this has been a very difficult time over the last 4 or 5 years. I sat on the board of a mental health company. It's the largest outpatient provider of mental health services. And one of the challenges that we have is managing the workforce, because the demand for them is really high. And when we think about workforce generally around healthcare, we know that's a problem. And I think, Jerome, I don't know if you were in some meetings, but I recall absolutely zero meetings talking about workforce in the 4 years that I was in government. We were dealing with all kinds of issues, but workforce was not one of them. And what that I think we should all sort of recognize was that there wasn't this focus. I'm sure there were some people working on it across government, but in terms of the leadership level, this was not something that was on our radar. And now what we see is an aging population that's creating a lot of demand in the marketplace. We also see that there's increased demand on mental health, and there's also increased demand for young people facing cancers and things that we just haven't seen before. So across the board on healthcare, there's just this growing demand, and we don't have the workforce. I mean, we simply don't have it. There were no plans of how we were going to address it, and there's no pipeline. And so this is where technology is really important. And I know that there were not any other solutions. And the things that we're talking about in terms of workforce, many of those things are going to take years to happen. So what do we do right now? And this is where the technology, I think, is really important, and it definitely serves a gap. It provides that gap for patients itself with those products, but I want to go back to what I was saying about providers, because at the end of the day, the providers that we do have in the marketplace, we have to take care of them. You talked about the appointment times for a child psychiatrist, and I can tell you my husband is a child psychiatrist, and so, you know, there's a lot of demand on weekends, and it doesn't stop, and it's very difficult to get those appointments. So we also, when we think about technology, it's like, how do we provide technology for the providers to give them more capacity? And that's more of the work that we're trying to do at Oracle. So for Oracle Health, I think people think of Oracle as, you know, big tech, which is exactly what they are in terms of, you know, think of us as a Google or an Amazon or a Microsoft, where they do big tech infrastructure and they build data centers. But what Oracle did a few years back was observing COVID, and they had done a lot of work in industries generally, so communications and retail and hospitality, and they go into industries and they come up with innovative technology for disruption. And I think they were watching all of COVID and thought, wow, like, we could really help here. This doesn't make any sense. We could solve this problem, and that problem. And I think we've all heard that from big tech before. But what Oracle did was very different, and they said, well, we're very serious about this. And they spent $29 billion, and they bought an EHR company. They did not buy this EHR for the technology, but they bought it to understand the data, and they wanted to understand the workflows and how hospitals work. This was the acquisition of Cerner. And for our founder, Larry Ellison, depending on the day, he's the richest person or the second richest person. But for him, this is a mission. And to sort of look across healthcare and say, this isn't working. It's not working for patients. It's not working for providers. It's becoming unsustainable for governments and employers. And so we really need something that's very different. So our mission and goal is to provide technology to drive that transformation across the system. And what we've been focusing on in the short term as we bring out a lot of our products is around this piece around the providers and the administrative piece to healthcare. So in all the stories that we just told, right, I'm thinking behind the scenes, like all of the darn paperwork that needed to get done to get these 5 people services and this kid this and coordinate and call this person and that person. There's a lot that goes on in a clinician's time that has nothing to do with direct patient care. It's because they're navigating the entire system. And in our country, we're spending about 25 to 30% of our healthcare dollars just on administrative costs, right? So let's call the insurance company and say, can I get an authorization for this or for that? And so that's what we're focused on, is how can we bring better technology to solve those problems, right? So that the clinicians can be focused on patients, and that's how we create capacity in the system while the workforce catches up to the demand. So I'll give you a few examples of this. One is, this is something I think is getting more widely accepted, is something around ambient listening. And what this does is it listens to the provider-patient interaction, and then it generates the note, okay? So if you think about this, most providers have, they may see a patient for an hour, but it's 45 minutes, and then the next 15 to 20 minutes is paperwork, because they have to write up the note, and they may have to be doing work with the school. They may have to be able to get a prior authorization, so they have to send some of the things from the medical record to the insurance company. What the ambient listening tool does is a couple of things. One, because it's listening in the background, the provider can really look at the patient. And I don't think that that's a small thing. In fact, I have a little a theory that when we think about trust in the healthcare system, that the erosion of trust was because the poor providers were sitting there looking at the computer and they were not looking at the patient. And it's hard to trust somebody that doesn't look you in the eye. So by having this ambient listening, they are directly looking at the patient. They're picking up on facial cues, which is very important in mental health. And the ambient listening then generates the note. They have the opportunity to review the note, make changes, and then the whole thing is done. And you can imagine that they can, something that took maybe 15, 20 minutes now took the ambient listening, the AI, in a minute or two. So that's one thing. Then the other thing that it's starting to do is coding. So you've got to get paid for these services to figure out what all the different codes are. And we spend a lot of time training our providers. There's back end, there's a whole back office that's figuring out what are the right codes. So the AI can do the coding as well. The AI can figure, the doctor said, hey, we're going to put you on this medication. It can automate the whole workflow so that the prescription is actually filled. And then the other one is around prior authorizations. Now, when I was in government, this was the number one pain point when you talk to providers and payers. And so, there's a lot of work being done on the federal government level to automate prior authorizations. But what that means for the provider is, as they're coming up with their treatment plan, we can automate that whole process. So they're not doing this back and forth dance with the insurance companies, and we can automate that whole process. And what that means, not just for the provider, but there's also a whole back office. And that makes it very expensive. When you're delivering care, there's the cost to collect and just to administrate. If we can bring down those costs, again, it allows us to invest more so in patient care. So that's where I think that there's opportunities for big tech, as well as solutions that are out there for patients.
Great, thank you. And I'd like to reflect and maybe have folks weigh in on my reflection here. So it seems like a common theme throughout this conversation has been the idea of friction, right? So, and I say this, I'm going to tell on myself right now as a bad parent. So, my daughter needs to go to a pediatric dentist. Just complicated stuff, whatever. It's all a racket, I think, but that's a separate rant for a separate day. And rather than, make the referral for me, they give me this list and they say, will you call these people and explain the situation to them? And it took me like 6 weeks to do this, right? Like there's so much friction involved. And from my perspective, then Seema, you're talking about friction from the provider perspective. There's friction involved with, if having to have separate appointments for the kid and the parent, right? So it seems to me like I think what we're on the precipice of potentially, and this is really important, I think, for employers as well. Like, I hope the optimistic view here is that we are going to reduce friction on all levels of this system and make it much more user friendly, which then hopefully will be able to make it easier for you to have your employees use this system. Because it's not just like, hey, call this number, tell them your life story. If it doesn't work, call this other number, tell them your life story, and then all over and over and over again. So could you reflect on this notion of friction if there's any thoughts that come up? So,
I guess the reflection I would offer is really about engagement. And so one of the things we've talked about, anybody who has a healthcare practice, a healthcare company, there's people wanting the product and service, and then there's actually getting people to use it. And I think one of the metrics that's been really, really difficult for people to crack really across the healthcare system has been engagement. And I think that is, you've used the word friction to talk about that, and I do feel like things are so complicated. I mean, I'm sure every one of us up here who have a lot of experience with this system have stories. I'm dealing with elderly parents, you're dealing with kids. That if you can't get someone engaging, you're not going to get the outcomes that you're looking for. And so I think we can have all of the great solutions in the world out there, but if that engagement part of the nut can't be cracked, we're not going to see the results that deliver whatever social or financial return on investment we're looking for.
Yeah, this is something we've thought about a lot just from our own model perspective. So we serve largely hard-to-reach Medicaid families, and our engagement rate is over 95%, which we're told is pretty good. And I think the reason why is because every family gets a community health worker dedicated to the caregiver and a community health worker dedicated to the teenager. And so their time is spent on the human interaction of, how can I help you, like mom, re-enroll in Medicaid, or figure out food stamps, or go with you to school for the IEP appointment, or whatever it is. And then we have a tech team that's using AI and other tools to build the workflows for those community health workers so that they're not spending their time on bureaucratic administrative things, but have time, and I think also units of energy, like life spark, to give in these in human interactions. And so I think so much of this is less about how can AI be the care delivery, but rather like how can we use all these new tools to help the workforce be more human in care delivery.
I also think, I say with a ton of, bias about Flourish and Natalia, which I think Margaret has too, because by the way, full disclosure, we're both investors in Flourish. And the fund that I run is called Luminary Impact Fund, and we only invest in great family mental health companies and organizations to help them grow to scale. But what's I think really unique about your case on the friction point is that if Flourish gets involved with a community health worker and a really hard to reach family and child at the moment that you do, and your story really brought this to life, you can actually save not just the time and the life force that it requires to do that work, but also you can save, to Seema's really practical point, you can also save payers money, and you work with plenty of Medicaid plans. I'll let you describe more than me, but in doing so, you are 1/10 the cost of a child going to residential treatment because they didn't have someone come with them to school and work through the IEP and figure out what they needed before they were hospitalized. And that is like a very clear win, which is part of why you've been able to do these contracts. And to me, that's like the ultimate example of really how do you work through that friction. It's like you catch it at the right moment and you make sure that you're providing value and that you're saving money in that moment.
I mean, one thing I really appreciated, Seema, you bringing up the workforce part, because I had left that out. One of the things we're seeing a lot of, and I think this is a little bit of a double-edged sword, but what we invest in companies that serve people on Medicaid and other underserved groups, and we are seeing a lot of subspecialty companies and investing in a lot of subspecialty companies. And what we're realizing is that getting really good treatment for someone with an eating disorder or moderate to severe mental illness, that we're in pediatric endocrinology, we're seeing specialized companies doing that work because it's so full of friction to try to get access in the broader system. And I think that's great because we are seeing we're seeing kind of more effective distribution of scarce resources. Natalia's a adolescent psychiatrist, we've got pediatric endocrinologists in short supply, and we also risk fragmenting the system even more. So I think when we look at these companies, we see an incredible potential to increase access, and we also try to think about, and you guys have thought beautifully about, how do we do this without making this kind of completely separate from the rest of the system and the rest of care. So I think it's an important thing that we need to be focused on when we make those investments.
Yeah, we actually recently had a patient who had type 1 diabetes, and we were providing specialty care for his bipolar diagnosis, and he passed away from complications of diabetes. He was taken to the hospital one weekend. He was in the ICU getting the best care that his community hospital could give him, and he passed away. And after that, we did a lot of work on how can we better partner with pediatricians and other specialists, because it turned out that child's endocrinology team hadn't been able to reach him and his mom, but they were engaging with us 3 times a week. And so now we make sure when a child gets admitted to our program, if they're getting care from another specialist, we reach out to that office and we say, hey, we're in touch 3 times a week, 5 times a week, whatever it is. What do you need from us so that they can stay compliant with their other medical conditions? And I think one of the roles for big tech and tool development is how can we better communicate with other offices so that it doesn't take so much time. And then similarly, when we get a 600-page fax, can AI summarize that for us, please?
Yep.
She did say facts, just to let you know. Yeah. So that still happens in healthcare right now.
Yeah, I'm going to jump in on that one because I think this data, what I call data interoperability issue, really is a huge problem, and it hasn't been solved anywhere in the world. So we can take comfort with that. But I think we've done an extraordinarily poor job in this country. The government invested $36 billion in digital health records, but somehow when they put out the regulations, they forgot to say, oh, and by the way, they needed to be interoperable. Huge mistakes, and we are now kind of unraveling that. And you can see, this is a bipartisan issue that every single administration is trying to kind of advance this issue. But we need to be able to move data at the right time, at the right place, and with the patient. Not only so that the patient has it, the doctor has access to complete records. If you think about the example that you gave, the pediatrician, they may have no idea what you were doing and vice versa. And so I think we really do need to invest resources in data infrastructure to be able to have that sharing. It's important for care coordination as well. I think if we solve that problem in this country, it's going to have a massive ripple effect. The other issue is that our data is in disparate places. So, how many of you have like 4 portals on your phone because you've got some here and some here and some there? If we start to bring all of that data together, there's also an incredible opportunity to use AI and use analytics and summaries. That's also in our EHR, so you do get that summary. But now think about that in terms of researchers, being able to analyze that data and really thinking about what treatments work, what things do not work. And so I think that's also an important piece in our conversation today is the evaluation of the work that we do. And that's where I think AI can play a huge role in analyzing what services were provided, what outcomes did we see, so we can all learn from that.
Great. So we have a few minutes left here. So before we jump to audience questions, I'd like to invite everybody to kind of answer. So when I was at the state, I used to get emails every single day from somebody who would say, I have the solution to your problem, right? That was essentially like, and I got pretty desensitized to it because, I just didn't believe them. And so but what that taught me was, as you're sitting in these shoes as an employer or as somebody who is responsible for figuring out how to take care of people that are important to you, what are some lessons or takeaways of like how to distinguish between, what's real and promising versus what's, kind of not, I guess. So Natalia, we'll go in order.
Yeah, a lot of people, especially community providers or community clinic decision makers, will say, there's a lot of startups that talk to us about the great things they can do. How do we know who to trust? And one of my sort of really quick rule of thumbs that I can offer is there needs to be a full-time senior leader that's a clinician. And if there isn't, that to me is a red flag that business people are making decisions without a clinical voice in the room. You would never go to a hospital that doesn't have clinicians in decision making. And I think that is the first filter that I use that's pretty quick.
Super.
I totally agree with that. I'm so grateful that you are a clinician leading your company, by the way. And I think I would really elevate something Margaret said earlier, which is engagement. I think prior to the family mental health work that I'm doing now, I led a youth health nonprofit that served young people across the country. And I was just telling Natalia yesterday that to me, I was always so skeptical of solutions that would come to us wanting to be a part of our work. And when I'd ask them, how many young people do you work with? They'd be like, well, 400 or 800. And in our work, we were really privileged to work with 500,000 young people. And I was like, cool, come back to me when you're serving many more. Because I just couldn't take seriously what was happening, even if it was important and exciting, if it wasn't actually engaging young people at a scale that was meaningful, designed by them. And I think the same is true in family. So if you're making decisions about what potential innovation to work with, I would say make sure that you're seeing a scale at which it's operating, engaging the people it's trying to serve, and make sure that it's both a meaningful scale and that it's happening from the lens of the people that you're trying to serve.
That's great. This is a really simple one. You need someone to be really clear with data and with partners about the problem they're trying to solve. Not, this is an amazing solution in search of a target or a problem. And I often tell people, I want to see you come in as a company with community partners or healthcare partners who acknowledge this is a problem, who've shared their data so that you can actually talk about what problem you're going to solve together.
So I would add to that, I think those are all great comments. It's really about the numbers and the data, right? How many people are you serving? What kind of outcomes have you been able to achieve? And then when I think it comes to AI, this one's harder because I don't think we're as a community really have figured out how to purchase an AI product. So just a couple of things. One, understanding how that AI model was trained. Where did the data come from that it's underneath it, right? Because if it was trained on only 400 patients, was that a diverse patient population? Do they have a diversity of disease? So I think that really that really matters. The other thing that we haven't talked about, but just from a tech perspective, is security, right? There's a lot of tech solutions out there, and thinking through security is really important. There's a lot of hacking going on. There's a lot of cybersecurity risk. And I don't think that sometimes we appreciate that. In mental health, that's also super, super important. Privacy is really important. So I think that's something to think about when you're making technology decisions.
Great. Any audience questions? Nobody wants to be between us and lunch, so I think that's always the case. Oh, look, we got one. All right, we got a brave soul here, so.
Harvard put out a study I think it was in April, that said that the largest use of AI by the general public is relationships and therapy. And I'm just wondering, in terms of like kids in college today, they don't ever write an essay, It's like a lot of people are going to turn to that first before they go. And I'm just kind of wondering what your experience is with that in terms of, people aren't going to these very specialized AI systems for everything we're talking about here, but the impact of just ChatGPT, where people are going to first.
You want to start?
So a good friend of mine, and one of my former bosses, is head of healthcare at OpenAI, and we've had several long conversations about this. From my perspective, humbly, there are for clinically mild depression and anxiety, there are a lot of great tools that non-clinicians can learn how to support other people with, and that I think AI and ChatGPT can learn how to support other people with. So, for example, sometimes we have black and white thinking, or we catastrophize a situation, like how can we turn down the temperature there? I think the risk comes in recognizing when something is out of scope. So when would you expect a non-clinical community health worker or chaplain ministry to refer a patient to a clinician or to a hospital? And I think that's where we need some guardrails on publicly available AI. And the challenge for them, I mean, when you're available around the world, the infrastructure is different in every country. In the US, it's different sometimes in every county. And so I'm not jealous of that problem to solve, but it's one that they should tackle.
Yeah, I totally agree with everything you said. I've seen the impact of the kind of very low level of training that can, for a community health worker, even just like a peer supporter, have a big impact in the context of a helpline or support line. I work a hotline in San Francisco one afternoon a week called the Talk Line. We're all peer supporters. We're not clinicians. We can do, I think, a lot of good in that context as long as we know exactly what Natalia said, which is when we kick it up to our clinical supervision, that's the part of the AI-enabled relational tools and experiments that I think is like critically important. And where, to Seema's point earlier, I actually think we're kind of overly focused on that when we should be focused on what AI can do to make the relationships happen between humans better. Like AI can take out time, like you said, when you're in a clinical meeting with a patient, to give you the space to have 15 more minutes of looking that person in the eye, perhaps. So I think there's a lot of room to both put guardrails around the AI to make sure it's appropriate, just like I hopefully know my guardrails when I'm a peer supporter on the hotline, but also to really help the human interaction happen more, which is the huge promise in AI.
And I'd say as a recovering lawyer and bureaucrat, like it's a really hard regulation to write.
Right.
And so it's something we will have to wrestle with, I think, over the next couple years, but it's going to be really, really hard. And we should maybe ask AI to write it for us or something.
Yeah, and California's passed a number of bills last week. And one thing I would add to that, we talk to young people about this topic a lot, and they are going to go there. So we sort of have to start with the fact that that's true. And I think one of the things that I've been observing is that we have very rightfully grieving parents on one side and platforms on the other side, the OpenAIs and Anthropics. And what we're trying to do now is to get the voices of the experts in the space, of the adolescent development experts, of the Center for Digital Wellness and Center for Youth Thriving, and the organizations that are studying digital and mental health, and really try to get some more expert opinion out there on how those guardrails should be developed and written. Because to Jay's point, the legislation is going to start to happen at the state level. It's already, because it's not happening from the federal level at this point. And I think to the extent that that can be as informed as possible by people who have been deeply studying this, that is what we want to see. So we're sort of advocating and trying to give some platforms to some of those experts to get their ideas about guardrails out there.
Great. Seema, I'll give you the last word.
Well, no, I think this is going to be it's going to be a long process. I think that the regulators are taking it all in. There was some regulations that came out with the previous administration that talked more about at least just transparency, which I thought was a good start, right? They didn't go very far, but just to sort of say, okay, there's a requirement that you explain how your model was trained. So I think that's a good place to start. Usually with regulations, it seems like regulations are usually reactive. So something bad happens and then you write a regulation. And I think that's, unfortunately, then it becomes very restrictive. So look, this one, the private market, can give suggestions. I actually appreciate on this one that the government is watching and learning and observing at this point. In other parts of the world, in the EU, it's much more restrictive, and so they're not. My thought is they're not going to get all the opportunities and the promise of AI if you're trying to shut it down before it even really starts. So if you think about it, it's only been a couple of years here since we've just started to use these tools. So the tools are going to get better. They're going to evolve, and I think government right now is studying the problem, which is I think that's a good place to be right now.
Yeah, great. So my hottest take is that no more laws named after people, because I feel like that is like a pretty good rule of thumb. All right, well, please join me in thanking our panelists. This was amazing. don't know, Rachel, or am I announcing lunch, or are you? Okay, cool.
I got you. Unless you want to do that interview again.
No, thank you. She's a tough interviewer.
No, I'm not. But thank you, Jay and panelists, for an inspiring and forward-looking discussion. We appreciate your time. So thank you. Great job. And I hope you all are hungry, because now it is time for our lunch buffet. The catering team will come around and release you by table, but please use this time to connect and share conversations and practices with each other. We'll come back together at 1:15 for our closing session. Enjoy your meal.